are generally gunning for a child-specific drug. So all the treatments are off-label, but so is the use of low-dose aspirin to prevent first heart attack and stroke. So we have these 6 major groups of medications: antidepressants, traditional mood stabilizers, first-generation antipsychotics, second-generation antipsychotics, stimulants, and anti-anxiety agents. I left out a category, which is the unusual mood stabilizers, but I think the slide itself will have that. So antidepressants, again, pushed from below. They should be reserved almost exclusively for pure depressions. They can easily make bipolar patients worse or suicidal or homicidal. And unfortunately, it's become very prevalent to use trazodone to induce sleep. Trazodone is an antidepressant. So the paradox is the patient is having, if you'll allow me to go back to a slide, the patient is having these mixed mood disorder with depressive symptoms, but is also reporting to the doctor, I don't sleep at night. And the doctor gives an antidepressant, which we know if it's an antidepressant, it's going to tend to make things worse over the long haul, not better. So very important we not use antidepressants to produce sleep in somebody who has bipolar symptoms, let alone the fact that it can cause in males a sort of involuntary erection that sometimes has to be surgically reduced in the emergency room, and then that person does not have the ability to get an erection again. Mood stabilizers, most people will require more than one medicine, and the rule in psychiatry is the same as it is in general medicine, which is often 2 drugs used at lower doses will have more effect and fewer side effects than 1 drug pushed all the way pedal to the metal. So even lithium, when properly used, is effective 100% less than 40% of the time. So even if the diagnosis is correct, lithium is used, you will need other medications to be added to it to make it work. It is preferable to use mood stabilizers, not antipsychotic drugs, in the long run. So antipsychotic drugs, as we will see in a moment, are good for stabilizing people, but in the long run, we want to see the use of mood stabilizers, and you can see a rather extensive list here. And I'm sure you've heard of Tegretol and Depakote, and there are a lot of non-standard drugs as well. Antipsychotics are best used to manage agitation while you're adjusting other medications, just like we use Robitussin to manage a cough until we fix you by giving you an antibiotic for your pneumonia. But nobody would sell you on taking Robitussin for life. Unfortunately, these drugs are extremely well marketed, and as a result, the tendency is of the average clinician is to prescribe them rather extensively and not to take the time, which often our insurance programs don't support anyway, to take the time to properly use mood stabilizers, which takes a fair number of visits. They will just typically give antipsychotics till you make the symptom go away. So that doesn't mean they don't have mood stabilizing abilities, it's just that they tend to be more side effect prone in the long run and are not as good as preventing cycling in the long run. Again, there are also long-acting injectables which have particular use in non-compliant patients, but again, are they non-compliant because they're ill, or non-compliant because the doctor and the patient never worked out the side effects, or is it something else? Unfortunately, like most veterinary students, Doreen breezes through Chapter 9, and you see Chapter 9, no matter what the diagnosis, the treatment is to shoot. And unfortunately, we tend to see antipsychotics used in that way as well. Also, remember that, again, this is a, unfortunately, drug industry-driven phenomena, and you can have the latest drug is heavily marketed as being materially better than the drugs that preceded it. Sometimes, and maybe often, that's not true. And unfortunately, because of our bias, just as many people put the high-test gas in their cars where the owner's manual says that's not really going to help you in gas mileage or acceleration, in the same way people, even doctors, feel like sometimes the newest drug is the best thing, which I would caution one to think about carefully. Stimulants are really best only when there is ADHD or ADD. The problem is they can be calming in a young person. So if you have 100 kids running around without a diagnosis and you give them all a stimulant, a lot of them will sit down. Just because it works doesn't mean it's the right thing to give them. Just, we could, if the issue is the patient looks better, we can make every patient who comes to the emergency room with chest pain look better by giving them some opiates, some morphine. So in the same way, just because somebody is better, quote, on Ritalin or better on a psychostimulant, or even going back to the antipsychotics, better on an antipsychotic, it doesn't mean that they are being well treated and properly treated for their mood disorder. In the same way that if we used a mallet over the head from Home Depot or Jack Daniels, that doesn't, just because it makes the person calmer, it doesn't mean that's an appropriate treatment. The problem again is their appearance to be effective. This is the Dennis the Menace, where the guy says, "Remind me to buy stock in whoever makes Ritalin." It is easily and overly dispensed. It's very well marketed, and again, there's Ritalin and every son of Ritalin or relative to Ritalin marketed as effective. So an incorrect diagnosis can lead to inappropriate treatment, and inappropriate treatment can lead to long-term bad outcomes. So many people with bipolar disorder as adults, if you look back, as children, they were first diagnosed with ADD and given stimulants. So unfortunately, the illness is untreated or worsens, therapies become less effective, family, friends, and the school get burnt out, the student gets frustrated, normal development and maturity falters, and there's tendency to get into the wrong crowd, and there's ultimately increased suicidal or homicidal risk. The challenge is that many of the diagnoses are DSM illegal, which means they are not in the textbook. They are atypical in terms of the textbook, and there's a bias among parents, school, and students to not think about bipolar spectrum, which yields generally not overdiagnosis. Generally, it's misdiagnosis and underdiagnosis, which I think results in many bad outcomes. In the schools, our challenge is to recognize that there is a mental health problem, but again, they're not really tasked with that. They will be very clear and say we're tasked to educate. But sometimes their evidence, what they see, can be helpful in helping the family get a correct diagnosis, to figure out, is there a biological component? And again, they should be part of the process of figuring out, is the patient treated to better, just that reduced range of mood states, or is it in remission and well? Schools, families, churches can identify students at risk, create a culture of openness by destigmatizing the illness and communicating openly, that people need to talk with each other about what's happening with a kid, and we need to teach kids about mental illness so that they too can self-refer. What patients can do is describe carefully their symptoms, their history, their med use, their drug use, be skeptical about the accuracy of diagnoses and the appropriateness of treatment, and remember that spectrum illnesses are the rule, not the exception. If you're looking for the textbook, you're only going to get a small tip of the iceberg. We're going to have to differentiate between when somebody's palliated or just feeling better, and when they're in remission or effectively they are returned to what a normal range of mood state would have been for them. And it's important to consider getting an expert to confirm the diagnosis and agree with the treatment so we don't go down the wrong path for decades. Here are some resources: The Bipolar Child by Dimitri Papalos, and An Unquiet Mind, which is really about adults but is helpful to experience what it's like to be inside the mind of somebody who has bipolar disorder, by Kay Jamison, who is a psychologist at Hopkins. The website's bpkids, isbd.org, dbsalliance.org. My website has some articles that I wrote for Bipolar Magazine, and of course, the International Bipolar Foundation.org, IBF.org, which is also welcoming your tax-deductible contributions. And they, of course, are the sponsor of today's webinar. With that, my planned remarks are completed, and Debbie, I'm going to ask you to open it up to some questions. Are you guys still there?
Yes, we are. Thank you, Dr. Weisblatt. Once again, we are open for questions, and while I know you're typing, I will remind you that this presentation has been recorded and will be archived on our website at ibpf.org. If there's a question that you happen to think of after the fact, you can always email me at dbrown@ibpf.org. Right now, we have just a couple of comments, Dr. Weisblatt, that the presentation is awesome. And here I do have a question coming in. Are there any specific techniques for parents to get kids to open up and express certain symptoms that may be happening within?
I think that's challenging because both kids are reluctant to say what they feel because most kids are trying to please their parents, don't want to scare their parents. I think it's asking open-ended questions rather than are you suicidal as a starting point, but ultimately we have to be comfortable asking a kid, are you thinking life is not worth living? I mean, that's important to elicit. But to do the diagnosis really should be a professional doing the inquiry. And I submit that some of the inquiry should be with the kid and the family present together. Typically, my interviews are with the family and the child in the same room where I give a sort of presentation like this, much shorter, just to show them in diagram form about amplification and de-amplification. And by doing that, it opens up an opportunity for them to have the words to say, yeah, I feel that. Or a parent to say, yes, my brother was like that, which helps us in understanding the family history. It also opens it up to letting everyone know that these are things other people have experienced. And then at some point, I do kick the family out and speak to the young person alone because sometimes they really won't say stuff to their family members. So I think the formality of diagnosis should be in the presence of a clinician. But I think it's important, just as parents generally tell their children, you can tell me anything, it's important that you be open-minded and ask the kid what's going on, but they may not be able to tell you. But we don't want to have a parent take that shopping list of symptoms and sort of woodpecker at a kid, do you have this, do you have that, do you have the other? It's probably best to go for a formal consultation if there's a question. I hope that answers it.
Yes, great. Thank you very much for that. The next question, do you have specific tips for IEP or 504 meetings with schools?
Well, I think we have to understand that this is a diagnosis. It's a real diagnosis, no different than seizure disorder or anything else. So I think the question is, depending on what's going on with the young person, we have to also be aware that sometimes by giving information about bipolarity, it can label a child, and the school can misuse that information. And sometimes if we don't give that information, we can hurt the child because they think it's just a spoiled young person or a kid that just doesn't want to behave, quote, in a certain way. So I think it's very challenging to decide when to say something to the school and when not to. And I guess in some ways that really has to be individualized to the student, the family, and the school system. But when one writes an IEP, and if one is including bipolarity, then it should be that the kid should be understood to be a moving target. In other words, if I see a young man on October 1 who has a psychiatric illness, the perfect IEP on October 1st may not be the perfect IEP on November 1st. And certainly on December 1st, because if we treat the young person to remission, then they, in a sense, with therapy supports, go back to regular ed, potentially, and maybe not needing the same support. So it's important to understand that the IEP has to be modified, assuming the child will be actively treated, as opposed to warehoused. because otherwise we're not going to keep up with the moving target of how the young person is functioning when properly treated. There are tips about IEPs on the Dimitri Papoulos's website, and there may be some on BP Kids, and I don't know if IBPF also has tips on how to incorporate specific targets in the IEP.
Great, thank you for that answer. IBPF does not have specific tips. However, the others that you mentioned are great resources. Thank you. The next question is, what type of support can a middle school offer their students specifically to help destigmatize how mental health disorders are seen and supported?
Can you repeat the question again? I'm sorry.
Sure. So in terms of a middle school, what can staff provide their students to help destigmatize mental health disorders?
Well, I think some basic education about, just as you would tell a teacher if your friend was bleeding or had a broken bone sticking out, you would tell a teacher or somebody in school, you know, teaching the kind of things we teach in general health education to kids, as well as in how we care for our fellow man kind of thing. I don't know that we really, at the middle school level, want to try to give them a whole presentation on mood disorders, other than to talk about in general that if you hear this, then tell someone. And I think there are awareness programs. I'm not specifically aware of where one would find them on the net, but I'm sure there are mental health awareness programs that are middle school appropriate.
Great, thank you. The next question, my husband and I are living with bipolar disorder, and so is my sister. Hopefully my 4-year-old daughter won't have this, but for now, what can I do to ensure early detection in case she does?
Well, I think we have to understand that this is a generational illness, and often the child didn't get the disease out of the blue, but somebody in the lineage, whether it's an uncle, a parent, a grandparent, had some form of mood disorder likely as well. So I would advise these parents to really make sure they are treated to remission. Remission being that there are no symptoms present and there are no adverse effects of medicine that would make them not want to continue their medicines, so that they themselves are in the best place emotionally to be grounded in terms of their moods, thus to recognize more accurately in their child if the child departs from normal mood range. As well, they hopefully are already plugged into the clinical system and using the information they got today, as well as their own clinicians, would have a sort of early warning system of mood changes in the child. And I think it's a lot to ask, but I think it's doable, and I certainly advocate that parents, you know, it's just like in the airplane when they do the flight briefing and tell you put the oxygen mask on yourself first and then your child, because if you're unconscious, you're not going to be able to help your kid with their mask. In the same way here, it's critical for the parents to take care of their own wellness, you know, prior to, you know, that's the best preparation they can do, I think. And then as the child ages, making good age-appropriate decisions about what to disclose and what to educate, so that the kid knows to report things as if they get symptoms themselves.
Excellent. Thank you.
Hope that answers it.
Yes, thank you very much. The next question. For children that were misdiagnosed with ADHD, may have been treated with stimulants or antipsychotics successfully, and where remission is near impossible to determine because the baseline has been skewed for many years of the previous diagnosis. How do you determine palliation versus remission levels to successfully manage the medication?
Well, I want to, there's many different questions there. We shouldn't be managing medications. We should be managing illnesses, just like we manage asthma and seizure disorder. And I think, yes, it can be challenging, but I think working together, and again, this is unfortunate because all too often families don't have access to clinicians who have the time, and the insurance company won't pay for the time for them to meet on a regular basis for a fair amount of time, more than a 20-minute window, to really dig into, are we well or are we just better? And I think we need the time, and we should be lobbying insurance companies or insisting on getting that level of care. Because in my experience, whenever I hear of a non-responder or have been referred somebody who's been labeled, oh, they've tried everything and nothing has worked, I have never encountered a patient where everything was really tried properly and where nothing worked. I just haven't seen that. Most often it's either a diagnosis problem, a treatment problem, a doctor-patient collaboration problem, but I've never seen an illness that didn't roll over and play dead when you properly treat it. So I would be very cautious before anybody takes the position of, really, we can't do better, really, this is as good as it gets, or, gee, we'll never sort this out. I don't believe, given appropriate clinical resources, that that's truly the case. The problem is, I think, is a resource problem.
Great, excellent information. The next question, what are your thoughts on TMS with children and young adults?
TMS is currently, I believe, and I may be wrong about this, but only advised as a possible treatment for depression, unipolar depression. I do not believe yet that we are clear that it is a mainstay of treatments for bipolar disorder. It's something to watch in the future. But I think, to be candid, even though it's a very scary word for people, lithium, if you go to the International Society for Bipolar Disorders and you meet experts in bipolar disorder, and imagine asking each of them, if you did a poll, you just got a call while you're at the conference, your kid's away in college, just got diagnosed with a mixed state or standard classic bipolar disorder at school, what do you want that kid to get? The answer almost uniformly will be lithium as the most well understood, best drug to give long-term good outcomes. So I think, though, TMS certainly is and that's transcranial magnetic stimulation, although TMS is certainly something we should keep our eye on for the future as a non-invasive treatment, I would be cautious about pursuing that as a line of treatment at this point in 2015 in lieu of good, aggressive mood stabilization with well-understood medicines.
Great.
Having said that, I just want to make one more point that I did not make earlier, which is there is a holistic sort of, not treatment for bipolar disorder, but a nutraceutical, a drug available from vitamin companies, essentially, that tends to help people with bipolar disorder, and that's the letter N, acetyl, ACETYL, cysteine, CYSTEINE, otherwise called NAC, NAC. And if you go to the website of something like Puritan.com and look up NAC, and the person takes 2,000 milligrams a day, that is another holistic way in a very mild individual, very mild, that you would potentially either add to standard treatment to decrease the number of drugs being used if possible, and it takes about 3 months to work. So it's not a powerful agent, it's more of a holistic, somebody looking to try an alternative first. But again, trying alternatives is really not something you have the luxury of doing if somebody's at risk of hurting themselves.
Great, thank you for that additional information. The next question, my child has a diagnosis, 14-year-old child, of ADHD and bipolar. He's currently taking Concerta, which works well, and Triliptol. My concern stems from his recent visits to doctors and behaviors. He's had minor procedures, and four people have had to hold him down, and he has full meltdowns, sobbing, curled up on the floor, rocking, etc., repeating he wanted to go home. My concern is that he potentially has some sort of autism. Can you comment?
That is not a hallmark of autism, that what you've said. But I think when I hear of an individual being duly well, let me stop. There's a principle you can look up on the web called Occam's razor. I think it's OCCAM''S. It's a principle of thinking that the simplest explanation for a group of phenomena is the most likely accurate explanation. So if you really have pneumonia and you have a high fever and a white blood cell count and you're coughing up green yellow goo and your x-ray looks like garbage, you could have tuberculosis and a sinusitis causing you to cough things up and a fever of unknown origin to explain those different symptoms. But that's far less likely to be true than just simply have a pneumonia with all these different pieces. So when I hear of an individual being dually diagnosed with bipolar disorder and ADD, I'm wondering if maybe that person is an incompletely treated bipolar, because generally if one sees trouble with attention, there may be that person may be palliated or better on their mood stabilizer, in this case Triliptol, but not well, and then the stimulant is being used to modify behavior but doesn't treat the underlying bipolar disorder. Also, remember that you're going to get sort of more wild symptoms on stimulant, much like if you gave somebody cocaine. So I would be questioning the diagnosis, frankly, and the treatment program, because it sounds like there's still amplified range of mood states, amplified speed of mood changes, low frustration threshold, and amplified irritation in the description you just gave me, which indicates to me a partial treatment. And again, I should give the caveat, if I didn't examine this person and therefore I don't know this person and I can't theoretically make specific pronouncements about this person, but given a story like that, that's what I would say.
Great, thank you. Next question. Let's see. My son is bipolar and being treated well. He's amazing. Let's skip. New question. 5 years ago, my son was diagnosed, he's now 8, with a mood disorder after he responded to stimulants with anger, aggression, and irritability. She prescribed risperidol, which dampened down the lability somewhat. We switched to Abilify when his cholesterol became elevated. He is better, but not in remission. A new psychiatrist suggested bipolar as a new diagnosis and wants to try Depakote. We're very nervous about making a switch. Do you have any comments?
Again, we go back to lithium being the preferred drug of choice initially. And the risperidone, again, sounds like the typical use of an atypical antipsychotic or a second-generation antipsychotic. The risperidone was useful. It decreased symptoms, but it wasn't treating the underlying disorder to remission. And it's certainly not a mood stabilizer per se, although it has some mood stabilizing properties. So again, I think whenever one is treating and thinking of the long term, because remember that we're not treating, our horizon for what we're doing should not be a week, a month, a year. It should be the next 80 years of this kid's life. Then I think we have to think about stabilizing mood and preventing further illness and treating to remission. I had written a paper with Bob Post and some other leaders in bipolar disorder, and we made some rules for treatment. And the first rule was a three-parter. Treat actively, which means you don't see somebody once a month initially. You see them once a week or however you need to see them to treat them actively, as in quickly. 2, remission, which means completely well, early in the disease, because we don't want to let that brain practice having swings of mood. So again, I would advocate that although they are anxious about a transition should be made to a mood stabilizer, and lithium being preferential to Depakote as an initial drug, with all its attendant risk factors. If it's managed well and if there's no contraindication, then lithium should be the drug of choice still in this day and age.
Great, thank you.
Again, I have to say that's advice in general. To a case like this, I've never met the person, I have not assessed the person, and I can't give, in a sense, individualized advice. But lithium is the better choice as a long-term initial drug for mood stabilization, remembering that even if it's properly used, less than 40% of people will be completely remitted at the end of it. But then one would use then either Depakote or carbamazepine or oxcarbazepine, Tegretol, Equitrol, Carbitrol. We used one of the oxcarbazepine drugs, which I'm now forgetting the brand. Trileptal and Oxtellar are the brands of that. But those are better than being on the antipsychotics.
Excellent, thank you. Can you give us your views on the importance of therapy along with medication?
My views are really based on the literature and a best practice understanding, again, going to that biopsychosocial model we discussed earlier, that happiness does not exist in a bottle. All the bottle does, if it's treating the patient to remission, is turn off the amplifier. Doesn't help you with the channel. So if you can understand the analogy to TV, the amplifier is adjusting or amplifying the experience of the person of life. So for example, if a person has some life issues, it's going to magnify them. But when we stabilize our life issues and cope better, we are troubling our bipolar disorder less. So in general, I think everybody should be in some form of therapy to help them in the long term manage lives in a less stressful way. Having said that, there are some very particular situations where that may not be the case for that particular individual, but those are rarer. So no happiness in a bottle.
Great, thank you. Let's see, next question. Sorry, I'm scanning. My 15-year-old son has depression, social anxiety, and selective mutism. Just entered a therapeutic school with no medications. I am his mom and have bipolar 2. He has been given 20 milligrams of Zoloft in the past, and it did not help. I see what you described in my son, and will share with my psychiatrist at school that it sounds like he has bipolar spectrum disorder. Can you comment?
Sounds like whoever wrote that question is already on the way to getting better care. You know, again, using our, is my screen still visible? Is my screen still visible to them?
Yes, it is. Sorry. Yes.
Okay, so if we look again at this issue where the words you use, repeat the words about the child's presentation initially.
I'm sorry,
Debbie?
I don't have that again. Can you, whoever wrote that question, can you please retype that to me, please?
It's all right. I think it was, anxiety, and there was something about mood, and mom had bipolar.
Yes.
And again, if you imagine that obviously from a genetic point of view, the likely disorder the kid would develop would be in the bipolar spectrum. And mom says the kid got an antidepressant, which didn't help. So again, on this slide, the antidepressant would either not help or make things worse. So I think she is right. She is exactly correct that this is exactly why we need to make more prevalent this understanding so that fewer antidepressants are erroneously given to people who have bipolar spectrum illnesses.
Great, thank you. The next question is, my son was prescribed lithium for his bipolar 2 disorder. However, it needed to be discontinued after, due to GI problems. Is there a second best choice?
My second best choice in general is carbamazepine, otherwise known as Tegretol, Equitro, or Carbitrol, all different forms of the long-acting carbamazepine. There is a particular way to use that agent, but it is a well-known agent with 35 or so studies behind it, and it is a very useful medication and has more of an antidepressant punch than Depakote or valproic acid does. The one caveat I would say is in people who get upset stomachs with lithium, sometimes that is dose dependent or blood level dependent, and it behooves the clinician and the patient to work together to figure out, is there a lower dose that the person can tolerate if they take it in the middle of a meal in the extended release form. Because in some patients, even if their blood level is below the level we'd like to see, we're still getting a bit of a kick from the lithium, and as long as it's not bothering the person and all they have to do is remember to take it in the middle of a meal, if the person has that kind of discipline, then it's you're increasing the odds that then when another agent is added, you're likely to hit a home run and get that person in remission.
Great, thank you. The next question, what can teachers do to help students that they know are living with bipolar disorder?
So the question presumes that the child has bipolar disorder and is not treated to remission, because if somebody is living with bipolar disorder and they are treated properly, that shouldn't be present in the school. In other words, if I have bad vision, which I do, I'm legally blind without my glasses. So if I go to school as a student and as long as I wear my glasses, my vision is 20/20, the teacher has to make no special dispensations to me, because with glasses, I see like everybody else sees. If a bipolar patient is truly treated well to remission, their mood is like everybody else's. It responds to the environment and is not amplified in either direction. So if teachers are finding bipolar students that have symptoms, we must presume they are not treated to remission. And then I guess, assuming the school system will allow them, to convey to that family resources in the area that may be better able to help that student be treated to remission, so they don't have to still have struggles because of active, ongoing, partially treated illness.
Excellent, thank you. I know that we have a number of additional questions. However, I do need to end the webinar, but I am happy to receive your question via email, and I can forward that to Dr. Weisblatt. My email is dbrown@ibpf.org. You can go to our website and also send the question through our direct contact. And I want to thank you very much, Dr. Weisblatt, for sharing your insight and information with us today. It's been amazing, and we thank you very much for taking the time.
Thank you so much for the opportunity to speak to these folks. I appreciate it. Thank you.
Great. Everyone have a great day.